am Dr. Saroj Kumar Kothari. Today, I'll talk about latest update in hypertension with special emphasis to control of hypertension, daytime hypertension, office hypertension, and nighttime hypertension. And what are the benefits of controlling high blood pressure in terms of multi-organ damages and death. As per WHO, nearly 63% of total deaths in India are due to non-communicable disease, of which 27 are attributed to cardiovascular disease, which affects 45% of people in the 40 to 69 age group. Raised blood pressure is among the most important risk factors for cardiovascular disease. Moreover, it remains poorly controlled due to low awareness about hypertension, lack of appropriate care through primary care, and poor follow-up. In India, the prevalence has also gone up over 30 years to 38% in men and 32% in women, from 29% and 28% respectively. Despite that, nearly half of the people, or 51% of the men and 41% of women with hypertension, were unaware of the condition. Additionally, over 62% of the men and more than 53% of the women living with hypertension did not get treatment. Medications was used to control blood pressure in fewer than 1 in 5 men and 1 in 4 women with hypertension worldwide. This is published by Lancet, a reputed medical journal, in 2021. International Society of Hypertension, that is ISH, has released the ISH 2020 guideline, hypertension practice guideline. The inclusion of optimal and essential treatment paradigms attempts to address the issue that in resource-poor settings, optimal care refers to evidence-based standard of care, and whereas essential standards refer to minimum standards of care to allow specification of essential standards of care for low resource settings. The American Hypertension Association, AHA, and American College of Cardiology, ACC, has released a scientific statement in 2021 offering new guidance for management of stage 1 hypertension among patients with low atherosclerotic cardiovascular disease, that is ASCVD, risk. Among low-risk adults, no ASCVD or 10 years cardiovascular disease risk less than 10% with stage 1 hypertension, blood pressure 130 to 139, and diastolic 80 to 89 millimeter of mercury. Management starts with non-pharmacological therapy. If blood pressure remains uncontrolled at 3 to 6 months, then consideration of starting pharmacologic therapy starts. Acute respiratory distress syndrome, ARDS, is a potentially fatal condition involving lung damage, and experts often associate it with severe COVID-19. A recent study, which appears in the Journal of American College of Cardiology, reports that metoprolol can reduce lung inflammation and improve respiratory function in people with COVID-19 induced ARDS. Lowering systolic blood pressure targets down to the 110 to less than 130 millimeter of mercury range substantially reduced CV adverse events in the STEP randomized trial, affirming the SPRINT finding for an older Chinese population. Among some 8,500 patients ages 60 to 80 in China, the intensive target trimmed 26% of the composite CV risks. Finding from now a second major trial supporting a lower targets could unite the guidelines, which even among US professionals societies ranges from threshold of 130 to 150 millimeter of mercury. With regards to prognostic value of ambulatory blood pressure monitoring and nighttime blood pressure, the 2018 European guidelines on the management of arterial hypertension recommended that the diagnosis of hypertension should not only be dependent on office BP measurements, but also on out-of-office measurements, such as ABPM, that is ambulatory blood pressure measurement, or home blood pressure monitoring, HBPM. 24-hour and nighttime BP measurements were associated with greater risk of mortality and a composite of CV outcome. Thus, they may be considered as the most relevant measurements for estimating CV risk. For every 20 by 10 millimeter mercury increment of blood pressure measured at night, the risk of mortality increased by 23% and the risk of cardiovascular events by 36%. Most patients with hypertension require lifelong medical therapy to achieve optimal blood pressure control. The 2018 European guideline equally recommended 5 classes of antihypertensive drug considering high non-adherence treatment. The importance of combination treatment is particularly highlighted to improve adherence to therapy and BP control. Therefore, the 2018 European guidelines recommended, especially in the context of lower BP targets, to start antihypertensive therapy with an initial dual fixed dose combination of angiotensin converting enzyme, that is S inhibitors, or ARB, and angiotensin receptor blockers, plus calcium channel blocker or diuretics. Since early July 2018, products containing valsartan have been recalled worldwide. The reason is the detection of a known carcinogen, namely N-nitrosodimethylamine, NDMA, which can be found in candesartan, irbesartan, losartan, olmesartan, and valsartan. NDMA has been classified by WHO, International Agency for Research on Cancer, to be carcinogenic in humans. If 1 lakh patients would have received NDMA contaminated valsartan from Zhejiang, Huai manufacturing site, where the highest level of contaminants were found every day for 6 years in the highest dose, it could result in 22 additional liver cancers over the lifetime of these patients. So, a drug which lowers blood pressure or used for cardiovascular diseases, if causes cancer, we should be very careful about that. But valsartan recall, accompanied by a significant increase in the rate of emergency department visits of +6%. The HYGEA study represents the largest study that tested nighttime antihypertensive treatment. In this trial, chronotherapy was associated with a significant reduction in endpoints, including death. The HYGEA chronotherapy trial tested whether nighttime therapy in comparison to usual upon a hypertension therapy exerts a favorable CV risk reduction. The largest study included a total of 9,084 hypertensive patients during an average follow-up of 6.3 years. 1,752 participants experienced the primary CV outcome. An ambulatory BP measurement was performed for 48 hours to collect data on how BP differed during sleep. The RR, that is relative risk reduction for cardiovascular events, was significantly improved for nighttime treatment when compared with awakening treatment. Thank you very much.